good morning. It's great to see you all this morning, bright and early. I'm Dr. Caudle. I'm excited to be here. I call these gentlemen the dream team because it's truly an honor to be with them and kind of learning about their perspectives with healthcare. So I want to introduce you. We'll start with Dr. J. Bhatt. Dr. Bhatt, Dio, is the Senior Vice President of the American Hospital Association. He's also Chief Medical Officer as well. But in addition, he's the President of the Health Research and Educational Trust. In his role at the American Hospital Association, Dr. Bhatt helps physicians across the country understand health policy. He is known by his patients as well as the dancing doctor. So make sure you ask him about that later. So Dr. Bhatt, welcome to the program. Thank you for being here.
Thank you.
Next, we have Dr. Jeffrey W. Morgan, DO, MA, FACOI. He is the Dean of A.T. Still University School of Osteopathic Medicine in Arizona. He's also an Associate Professor of Internal Medicine. Dr. Morgan is a general internist. He's also Fellow of the American College of Osteopathic Internists. He's provided primary care medicine in Arizona for 18 years prior to joining SOMA in July 2013 as an Associate Professor of Internal Medicine and Public Health. So welcome to the program. Thank you for being here. Yes, round of applause. Yes, there we go. And for Dr. Bhatt as well. This is great. And last but not least, we have Mr. Joe Wilkins, MBA. He currently serves as Senior Vice President and Chief Transformation Officer at the Atlantic Health System. Mr. Wilkins is board certified in healthcare management as an American College of Healthcare Executives Fellow. He earned an MBA in finance from Argosy University, and he is certified in population health management by the California Hospital Association. Welcome to the program. Thank you for being here.
Thank you.
Yes, absolutely. Okay, so let's begin. So we have a lot of sort of intense questions, and I love that you all, as experts, have a really diversity of experience. So let's start really by framing this issue. And from each of your perspectives, what's it really going to take to move communities from healthcare to health? Dr. Bhatt, why don't we start with you? What are your thoughts?
Sure, thank you. And let me just start by saying thank you to the American Osteopathic Association for the invitation. We know that employed physicians are growing at an increasing rate, and so it's critical for the osteopathic physician community and hospitals, America's hospitals, to partner effectively together to improve community health. We know 60% of the issues that contribute to premature death are attributed to social factors, and then there's genetics and behavioral factors. So traditionally hospitals are thought of a place where people go to get care, but hospitals and physicians together could play an important role in addressing the deeply rooted social, economic, and environmental issues that impact the health of Americans. And so it's a mind shift that we have to advance in thinking upstream. And at the AHA, we're redefining the H. We're helping the field redefining H, and our members are redefining the H so that it goes from hospital to health system to health organization. And redefining the H means adjusting this new reality of the intersection of health and health care. And so we're seeing extraordinary examples around the country where hospitals and health systems are thinking differently about their services, about the community, their training, so that we impact the health of Americans upstream. And you'll hear more about this later, but also thinking about redefining the H as we redefine the journey from volume to value to impact the health of all Americans.
That's interesting. The word redefining keeps coming up, this idea of redefinition. Curious what you all think about that, or other ways that we can really move healthcare to health. What are your thoughts about that?
I love the idea of moving from volume to value. I really do appreciate it. I think there's a really tremendous opportunity for us to begin focusing tomorrow's physicians' attention on community health as it impacts individual health. I think there's a great opportunity for all of us to engage in showing our future physicians, as we educate them, the meaning of wellness as it comes from the wellness and the health of a community. And so to that end, ATSU SOMA, the School of Osteopathic Medicine in Arizona, began embedding students in community health centers over a decade ago, so that they learn in a contextual environment about the factors that affect individuals. If we work backwards from the health outcomes, and we look at things like quality of life and mortality and the health disparities that people experience, we know that there are determinants that impact those and subsequently policies that influence the determinants. And so part of that equation, I think, has to be advocacy at all of our levels.
Interesting. Mr. Wilkins, any thoughts about this?
Absolutely. So from healthcare to health, this is a question that healthcare systems and hospitals have been contemplating and asking for some time now. And as a result of that question, to Jay's point, we did develop a strategic plan around how, in fact, do we advance healthcare in America. And clearly, it requires a commitment within all entities within the healthcare enterprises. And there are a few key elements that we as health systems have committed to be sure that we are party to and help facilitate moving our organizations into the ability to deliver healthcare to our communities. So those aspects have to do with access, equitable access, affordable access to care is the first commitment that we want all our hospitals to commit to going forward. We also know that value is a key part. Value, being accountable for value-based care is another key component of what we would see for the future for us to advance health care to health. And then partnerships. We know as health hospitals and health systems, we can't do it alone. We need to partner with wonderful physicians like DOs. DOs here make a huge difference in care in our vulnerable communities. So partnerships are critical to the future, but we also need to partner with pharma. We got to partner with the health plans. So partnerships are crucial as well towards the future. And then finally, just respects to wellness. Changing our mindset from sick care to well care is important. That's a different way of thinking. It really is about investing in our communities and not into so much our infrastructures in our hospital settings. And then somehow we have to employ innovation in terms of how do we change our business model, our delivery care models with innovation. Technology can make a huge difference for the future. I would just pause to say again, it is an honor to be here with such a group of wonderful physicians that are dedicated to holistic care. Really treating the whole body, mind, and spirit is a key element to our success.
Yeah, that's great. You know, you all had really interesting points. You talked about sort of redefining care and redefining how we think about things. You talked about, so even your students and how they're in community centers very early on. 10 years ago, you started that. Mr. Wilkins, you talked about access and affordability and partnerships commitment. It brings us to our next question, which is really, I think, sort of a culmination of a lot of these things. You know, there are more Americans now, more than ever, with health insurance. So how is this changing our approach to community-based care? How is this changing that? What are your thoughts?
So I would say that one, we can't reverse the gains that we've made. I think those gains have been critical to helping move us to thinking about community health. One, cultivating partnerships through value-based care. I mean, you're seeing healthcare delivery organizations partner with community-based organizations, with schools, with the health department, with unlikely partners to really advance health. And I think that that's critical. The other I would say is when you think about people with chronic disease, right? As an osteopathic physician that sometimes see patients who come to us at the front door where they've carried their chronic condition for years, now that they have coverage, they're not fearful of trying to get care, and we still have to translate coverage to care, but it's a start. And the opioid epidemic is another example of how coverage has really made a difference for some of those patients.
Right.
If I may,
yes, please.
I want to add that it isn't just about a physician shortage in the United States that your question has impact on. The increased number of individuals who have access to health care necessarily increases those entering the front door of a physician's office, and there are certainly too few physicians to meet that demand. But more importantly, a lot of those people that now have that access to health care coverage are some of the sickest people, and historically they've gone to community health centers, centers that serve 25 million Americans, regardless of their ability to pay. And those particular centers are represented in terms of workforce in particular.
Yeah.
And I would just again second, we would not want to go backwards. You know, it takes quite a bit of time for new individuals to get into the healthcare system. Just to find a primary care provider is challenging and difficult. So by the time you develop that relationship and over a period of time of seeing your own behaviors change as a patient and that relationship with your provider, just takes time, and we want to make sure that we have consistent access over the long haul, as we will see the most gains in reducing our costs for healthcare across America.
Yeah. You know, what I'd like to do is kind of piggyback on this and combining two issues that I know we're going to touch on, which is primary care and the role of primary care physicians and the role of primary care right now. But I'd like to combine that also with this concept of access, which is what you all were just talking about. And my question is, does access automatically mean access to care? Does it automatically translate to improved health status? Are our patients healthier because they have access? Is it synonymous? And if not, what are some of the barriers? And maybe if you can throw in your thoughts about primary care along with that, it might be, you know, helpful and interesting. Yeah, your thoughts.
So, you know, I think we've got to continue to work to translate coverage to care. If people go back to conditions that make them sick, they're not going to be healthy, right? Mm-hmm. So we may take care of them in the healthcare setting, whatever setting that may be, but if they're in unsafe neighborhoods, if they have to take multiple modes of transportation, if they have food insecurity, or they can't afford their medicines, yes. That's going to be a problem. Or if there's health literacy challenges. So that context is really important. And I think that the value-based care arrangements, those experiments from accountable health communities to ACOs have allowed us to think about what's the right kind of care that patients need. And it may not involve an ICD code, right? That we need to think about what are the kinds of partnerships. And then we also think about what we do in terms of building infrastructure. So there are situations in which we need to create access point in a community. And we went to the community to create that access point, but then when you talk to the community members or the police force, they say, well, why don't you move that clinic 6 blocks this way, and then actually you might get better access to transportation, it'll be safer. And so when you're thinking about even just designing, the context of the community matters in it as well.
That's a really great point, contextualization and keeping these elements in mind. I remember when I was a young physician working in Baltimore, I remember I could pretty much predict which patients I would see that day based on the weather, because most of my patients took buses. So if it was raining or snowing, I knew I wouldn't see people. If it was the end of the month, when checks weren't received till the beginning of the month, I may not see patients. So I totally agree with you about contextualization and really working with communities to help access mean improved care.
In addition to the points that Jay made about lack of transportation, ability to pay for medications if a prescription's given, et cetera, those things are weighed against need for food and safety. Right. Access to care doesn't change behaviors, and so it's effectively getting into families and communities and changing behaviors that I think ultimately has the bigger impact.
Interesting.
And it goes back to, you know, the relationship between the provider and the patient. It's got to be built on trust. And, you know, when people come into the health system for the first time, there isn't a lot of trust. And so we have to find a way to better socialize that trust relationship, crucial to success. Right. And it's got a lot to do with cultural competency across the board in America. I was just at an event the other day, and, you know, the story was from this community that are just sick of being sick, and
right.
But yet afraid to engage the system.
Right.
So it's just there.
No, you're right.
And I would just build on the notion that, you know, you can't get to quality without equity. So if we're not eliminating disparities in care, then we're impacting quality. So you may have access, but if care is delivered differently to people because of their context or because of the lack of sort of cultural competency or translation, then in literacy that may have an impact as well. And, you know, I think osteopathic physicians and primary care physicians have a really critical role to play to help change the conversation for patients and to set them on a path to health. You know, when we think about diabetes and the challenges with that, we say, well, walk 30 minutes 3 times a day, do X, Y, and Z. But what if we had the data at the point of care to say, you know, you have a 30% chance of seeing your daughter at her wedding and dancing with her, or you have a 50% chance of making it to your son's graduation. Now, connecting health goals with life goals in a context that they can understand really matters.
That's really interesting. Along these lines, and we're talking about removing disparities and equity, I think that's a really salient point. Physicians and making sure patients are comfortable talking to us and accessing care. Recruiting physicians to train and work in underserved urban and rural communities continues to be a challenge. And this is something I think we all know about. And I don't know, did I mention that you were born and raised in North Philadelphia? Did I mention that? I don't think I did, but I mentioned that because of your experience in North Philadelphia. I know you've been part of National Health Service Corps, and I know many of you have experiences with different types of communities. So I'm really interested to know, from your collective experiences, what can we do to address the issue of physicians training and working in underserved areas?
So, it's exciting to come back to my second home here. I went to medical school at the Philadelphia College of Osteopathic Medicine, and the leadership of Dean Bhatt was critical to my career and path. And the experiences that I had in community health centers while being a student in North Philadelphia and West Philadelphia really helped shape my perspective on how we should think about care in underserved communities, as well as my time growing up in Southside Chicago communities with my dad, who was a pharmacist in those communities. And really, my interest in the intersection of public health and healthcare delivery was sparked by a barbershop in which we worked to put a clinic in the back end of that barbershop and help black men who would feel that they couldn't access care at the back end of this barbershop. So over the course of 5 years, the rates of chronic disease started declining. They started changing how they thought about health. And so we've got to think about, how do we meet patients where they're at and in places where they need. And I would also say, I say this a lot, that only 1 out of 5 physicians understand how to think about social determinants of health, but 100% of osteopathic physicians are capable of thinking about social determinants of health in their care, and it's because of the training and the holistic perspective we have.
And Dr. Jen, from an academic perspective, I think it's crucial that we have an opportunity to identify applicants to medical school who have a heart for service, who are interested in going into those areas of greatest need. In addition to that, we have an opportunity to embed public health-minded education in the students during their education, to the point that we can offer a Master's of Public Health along the way. So they're graduating with a focus on public health and the role they play in that.
Right.
I think
there's just one other point.
Sure.
I think that there's a huge cost to medical education. Student debt is very high. There's an opportunity for graduates today to go into public service, National Health Service Corps, et cetera. There's a national federal loan forgiveness program if you serve in a 501c3 or a nonprofit, which most of the community health centers or FQHCs are.
Sure.
And so there's a way to really kind of put a carrot out there for physicians to go into that area of service as well.
I'm actually curious. You're a dean of a medical school. Do you think that medical schools are doing enough to educate students about community medicine, community health, and some of the options and ways to practice and places to practice? And do you feel like we're doing an acceptable job in that realm?
I would say that my knowledge of the osteopathic medical schools, the answer is yes. I don't know that I can share that same answer when you look across both osteopathic and allopathic schools.
Yeah, good, very good.
Yeah, I would just add that, again, the issue around diversity in healthcare is a challenge, not only in the physician community, but in our hospitals. So we have a serious pledge around equity of care for all hospitals and health systems. And we've, at this point, I think we have close to 1,500 hospitals that have pledged, signed on a dotted line to ensure equity. And we know to get there, we have to have that in the leadership of the enterprise. And so we have done a lot around developing leaders like myself to be able to hold positions in senior leadership of our healthcare organizations that will make a difference. We also have been working with boards, hospital boards. We actually have a collaboration with the Urban League to kind of develop leadership from them to potential board seats in our local hospitals. And so I think that's going to help. But it's all around understanding the critical business needs around having a diverse leadership team, a diverse board that's going to be able to inform the strategies and decisions that need to happen for us to make progress. Today, more than 50% of every child born today is a person of color. That's significant in terms of us being ready to be able to address high quality care to a diverse community.
And I would just pick up, really applaud the leadership of Dr. Morgan in the way that he's challenged the conversation about what the future of medical education should look like. And osteopathic medical education, and the first step is embedding students in communities. But then what I see in the field is the challenge that hospitals and health systems have with strengthening clinical community linkages. And so the next step is embedding our students and residents in community-based organizations so that they understand what it takes to have those kind of partnerships. Because if you don't see it from that angle, it's a very different perspective of the challenges that the community-based organizations face. And we're going to have those partnerships as well. And I think, we're continuing our work with the National Urban League to create pipelines for diversity and leadership and governance, but also with UNIDOS and other organizations that represent diverse communities. And the notion that in some communities, the diversity issue is broader. It's not just race and ethnicity,
right.
But it's rural, it's veterans, it's those with disabilities, it's women. So we've got to think about the diversity piece from a broader perspective as well.
Absolutely. I want to shift a little bit now to talk about emergency rooms and emergency departments, which as physicians, we know we talk about this a lot. We see patients, we talk about access to care, getting into the office versus going to the ER, how ERs are used. And hospital emergency rooms have long been used as a safety net for patients without access to primary care. So what progress is being made to ensure that patients can get community-based primary care when and where they need it? I know that you talked a little bit about different ways to think about bringing healthcare to people. What are some other thoughts and ideas that you have so that we're using our resources appropriately?
Well, I'll start from a perspective of what we're doing as a health system is we've actually, through technology and big data, been able to really collect real insights as to the community that are often landing in our ERs. And so with that information, we're able to develop strategic plans, community projects to kind of really be proactive. So essentially what we're doing is going upstream. We are hired and are hiring more community health workers to actually promote health in those local communities where the flow of ER patients are coming into. So we think technology is going to be a key enabler for us to be able to improve in that area. But at the end of the day, we still need to be sure that we are proactive in promotion of health and wellness in all of our communities.
Right. That's a good point.
I want to come back to the community health centers.
Yeah.
They're a big partner with us, but in particular because they historically have taken all comers, regardless of their ability to pay. They serve 25 million people. There are 100 million office visits per year. There are over 1,400 community health centers across the U.S. at some 10,000 points of care for patients. The service that's provided in the community health center is comprehensive. It's mental health, dental, behavioral, primary care. It's everything that a patient needs in one setting. It's economic support, social support, that type of a thing. And the savings that brings to the healthcare system in the U.S. is to the tune of $24 billion. And the economic infusion in the communities that they serve is over $45 billion. And so I think refocusing on the community health centers across the U.S. and, again, back to policy, finding policies that support financially their continued existence is going to be critical.
That's a good point.
Yeah, I would certainly echo Joe and Dr. Morgan's sentiments and say that, we are facing a critical issue, as Adrian said earlier, about affordability. And so the notion is, what can hospitals and health systems do to take their ownership, their part on that issue of creating affordable care for Americans? And there's a wide range of stakeholders that need to do that. And turning the conversation and what it looks like about care in the emergency room is certainly an important part of one of those strategies. Redesigning care, operational efficiencies, quality and safety, sort of performance improvement, and value-based care. Those are really the four strategies we think about when it comes to affordability. And so it's thinking about virtual care. Mount Sinai has an incredible program they're launching and have been working on over the last 2 years called Mount Sinai at Home. And they submitted a payment model to the Payment Technical Advisory Committee that was approved now at the Secretary's desk. But the notion that if someone comes with bilateral pneumonia, signs of early sepsis, kidney failure, but can they be treated in a different place than the emergency room? Many of us would maybe admit that patient. But if we could take care of them at home, could they then avoid complications or adverse events? And so in this case, the story of a patient who ended up going home after being in the ER overnight, having fluids and antibiotics, and then at home, they started to have the conversations about goals of care, which you couldn't have in the emergency room. And then 5 days later, patient got to Kipnick, and then by that time, the family and the patient had decided about what their goals of care would be, and so they transitioned to hospice. And then over the next several weeks, had comfort care. And so the last 14 days of that person's life wasn't in the emergency room or the ICU, but was with 0 hospital days, with less suffering, and with their family at home. And so I think we've got to think differently about what do patients need, where do they need it, and how do we optimize health across the continuum wherever they are.
That's a really great point. Our time is running down, and I want to give you, before we do our closing, I want to give you the opportunity to comment on, put it this way, it's your choice. You've got a choice of questions, okay, choice of topics, because I think both are really important, and I didn't want to choose for you. So one is this concept of patient activation. What is it? How are you using it with your organization? Why is it important? And the other question is how your organization really collaborates with others, especially with competitors, and how is this driving innovation? So give it some thought, and I'd love to know what your thoughts are about either of those questions, certainly.
So I can kick off. One of the things that's really exciting to see, and it's very interesting, that fierce competitors are coming together to collaborate. So in Charlotte, North Carolina, Carolina's healthcare system and Novant have been fierce competitors for a long time. Yet they decided that they would think about their community together, and so identified 6 zip code areas where they saw patients coming to their emergency room at Novant that then would go to Carolina's emergency room, that would then go back to Novant's, then go to Carolina's, and they'd just shuttle back and forth. So the CEOs came together and took, with their teams, a bus ride through the communities and stopped off and talked to the people in the community. And what they identified was that the issue was, for them, an access point. In that 6 zip code area, there's food insecurity, transportation desert, but also access to care was an issue. So together they invested in healthcare access and interventions to address the social determinants of health, co-designed, co-owned, revenue shared, and the community saw that as people coming together, and that's what we've got to model if we're going to address community health, moving healthcare to health. And I would say there's 4 things that I'd leave you with. That partnerships among health systems, public health bodies, community organizations are the most effective ways to address community health. And so engage leadership, build a compelling business case to garner the buy-in and needed resources. Prioritize the initial focus. You can't address all of the social determinants. What is the one that matters most in that community, and then build from there. Strengthen partnerships, leverage unique strengths of community organizations and assets, and design seamless care coordination. And so I think that that, along with thinking out of the box, I say that Uber doesn't own any transportation vehicles. What would it look like for healthcare to be delivered in classrooms, in grocery stores, where nutritionists can actually have their office visit there and teach people how to cook and shop?
Very interesting.
Yeah, at Atlantic Health System, we call it co-opetition. And so we're part of our 6 hospitals as part of our Atlantic Health System. We also are tied into another 25 hospitals through what we call the Allspire Network. We meet weekly and we share best practices, clinical innovations. We really are doing some great work together that has not occurred in years past. So we're excited about that part of the partnerships between health systems working together and that fashion of co-opetition. Where we need help is collaborating better with the health plans and with pharma. That's where we have our biggest challenge, and that's where we have this cost challenge in healthcare and value missing element in healthcare in general. So we're really starting to step up our leadership and try and force these partnerships with those two entities that have a big play in our healthcare continuing as we move forward further along.
Great.
And I would say that the intersection of patient health, healthcare services, and the wellness of a community we'll call community-oriented primary care. And I'd like to see us refocus our efforts on that very specific topic, that we look at the wellness of a community and how it impacts individuals and how those individuals' wellness impacts the community. And then, of course, the role that the physicians in the healthcare community have in that intersection. So patient engagement, patient activation is critical in that regard. And I think I'll come back to the unique partnership that SOMA has with the National Association of Community Health Centers. It's an awesome partnership. And I applaud the AOA for pushing this conversation in this direction, that we can develop even newer and more unique relationships.
Oh, very interesting. Patient activation, yes.
Well, I was just saying, you know, how do we think, what does it look like to make the healthy choice the easy choice for our communities?
I think it's well put. Yeah, it's very well put. As we're coming to a close today, I want to ask you all, before we close, do you have any final thoughts, any other additional thoughts that you'd like to leave our audience with before we close today?
I would just say, really coming back to what this conference is about and what Ariana talked about yesterday, this work around community health is hard. The challenges we see, the issues that people face, and what they bring to us in that relationship, they're really difficult, from loneliness to depression to how are they going to make it that day for themselves and their family. And that's hard, given all the pressures that physicians have to get through their day and make things happen to care for people, that it's important that we do think about resilience and well-being and have really a collective effort to do that. And I would say the other thing that what this partnership illustrates is that we've also got to make great strides in bridging the cultural divide between administrative and clinical leadership. And that's going to be critical to advancing both high-value care, resilience and well-being, and the health of America. So thank you.
Dr. Bhatt's comments and the comments we heard last night from Ms. Huffington, I think, really can be summarized in 2 words: be present. Be present.
Yeah, it's a good mantra for us all to have. Yeah. Absolutely.
I just would reflect on yesterday. I was just impressed with the awards ceremony in terms of the value of serving vulnerable communities. That was just impressive to me that this group of expert physicians have that within their DNA to actually serve vulnerable communities. And so I think that should be highlighted even more so, the great work that's being done. But the final comments is, I think we know what we need to do to bring the healthcare communities. We know what we need to do. The issue is how we get paid for it. It is, you know, the innovation and the breakthroughs are there. But at the end of the day, those breakthroughs and that innovation is stymied by how we pay for healthcare. And so I think we got to be bold around figuring out this move from fee to service to more value-based care. If we can clearly put a stake in the ground there, I think the innovation and the change in the models and care models will drive forward to deliver healthy communities across the board. So hopefully we can get that,
Wonderful.
to happen.
Well, Mr. Wilkins, Dr. Morgan, and Dr. Bhatt, really thank you so much for your insight today. As you all can see, this is why I called them the Dream Team. Thank you all for joining us today. This was excellent.
Thank you, Dr. John.